Right, perfect. I'm just going to skip my introductions, but yeah, recently my work is focused a lot more on agentic foundation models for radiotherapy, and I think that would actually be a perfect thing to present at a generative AI collaborative meeting. But unfortunately, my work is the work that I'm going to be presenting now is stuff that I've been doing over the past couple of years, which are not really very focused on generative AI methods. They're more based on a set of methods that kind of are more like contrastive learning or self-supervised methods. But I do think this fits into a generative AI paradigm because a lot of like these multimodal models where you see a combination of vision and text together, they're usually pre-trained on a lot of contrastive self-supervised approaches before they're actually done in a generative style of training. So I hope this gives you still a good picture of how this can fit into a multimodal generative AI paradigm as well. Uh, and yeah, here's a rough agenda of what I want to talk about today. So I'm going to start off with like why work on imaging foundation models at all. Then I'm going to talk about like one of the first studies we did in this space, which is building a foundation model for cancer imaging specifically, and then a study where we extend whatever we saw from study one as insights, and then try to build a model for structures on CT beyond just cancer. And then we're going to go back a little bit to cancer imaging and try to see over the past couple of years, there's been a wide range of foundation models specifically for CT. And we're going to try to see how these work well, how these work for cancer imaging and if they work well at all. So I say rough because I'm just going to allocate time based on how people might ask questions and if you would stop me or not and what you would find more interesting. So, please feel free to just chime in and say that you would want me to explain some part more, and I'm going to spend more time on that and lesser time on things that are less interesting to you guys. Okay, so just to set a bit of shared context, like if you think about all the tasks that a radiologist performs in their day to day, this could be something like looking at different modalities of scans, like CT scans, MRIs, ultrasound, X-rays, and then performing different tasks on these scans. And this could be things like detection of abnormalities. You could use these scans to also do interventional procedures, such as an interventional radiology. You would probably want to like measure and quantify things on scans. For example, if you want to look at like treatment response, if you want to look at things like RECIST criteria, this is what you would kind of want to do. You would probably also want to like segment and do a lot of segmentation tasks, especially if you're in radiotherapy, which is where I'm extensively working right now. If you would want to segment organs at risk, tumors, that's something that you do. And then one of the most common things I would do is like just making a comprehensive report from this imaging so that this can be passed down the chain of healthcare administration, and then you figure out what happens in the process flow of what is done with this patient later on. Of course, this is a non-exhaustive set of tasks, and there's obviously far beyond what I've listed here. Um, and what you see is radiology is also a high demand livelihood. That you see that this market for medical imaging systems that I've put in this like graph on the left here. This is kept on increasing over the past couple of years. And when this sort of market increases, you see that like jobs in this market also increase, and you see that like there's like more jobs being posted across just a couple of quarters and from 2019 to 2022 on an ECR job board. And then the compensation for radiologists, both non-interventional and interventional, this has also been increasing over the past couple of decades. So this is all pretty good, right? Like if you have the medical imaging market increase in size, more radiologists are better paid. This is great because more imaging means you can probably screen people better, diagnose people better, treat people better. So what's really the problem, right? So the problem is it's a high demand livelihood, even in terms of what is expected out of the radiologist. So if you look at the number of diagnostic images that a full-time radiologist would be seeing, and this is like if you look at like just from a slice or like a single image perspective, even with things like CTs being now higher resolution, you can get things at like a lower slice thickness, which means you just have more images to look at. And like this has led to a huge spike in the number of images that a full-time radiologist might see. And this would then potentially lead to radiologist burnout as well. So if you look at like statistics on what contributes the most to radiologist burnout, one of the largest contributors is this lack of respect from, spending too many hours at work. And that's like 48% involved that this would be the largest cause for radiologist burnout. So um, this is definitely a bad thing, right? So it's kind of great that advances in AI are moving from just general domain and various other verticals also to radiology. And you might have heard some of these names. A lot of them are like really popular and being used quite widely as well. Um, Specifically in research, I'm not sure if they found any sort of commercial applications as of yet, but I would be willing to bet Google is starting to find some place commercial applications here. Um, but yeah, some of these models such as MedPalm-M, MedVersa, Myra, CT-Chat, they all do very different things. But at the end of the day, they try to kind of um, provide support or even independently do some of the tasks that I mentioned earlier, such as like segmentation or report generation or some sort of categorizations or trying to find out if there's certain anomalies in certain images. Um, so yeah, there's a wide range of models that are already kind of being developed in radiology to kind of support the radiologist. Um, Now, if you look at how a process flow happens in radiology with like a radiologist trying to come up with an interpretation of an image, right, which might consist of like the patient history, what you would find as a comparison with the previous image, their impressions, their findings. This is a very multimodal process, and what I mean by multimodal is it involves a lot of different sources of data or different sorts of processes to generate this final output. So if you think about the different sources and you categorize them in terms of like what is immediately obvious to what becomes more and more abstract, what is immediately obvious kind of, or at least relatively, is like current and previous imaging. So this could be like your current time point scan and something that was like collected 6 months ago, 1 year ago, whatever, right? So what I mean here by that it's less abstract than the others is that um, you can clearly point out to what might be an anomaly in an image or what's something that you might want to pay attention to. And then as you go down this more abstract hierarchy, you kind of go down towards things like, getting knowledge from like whatever your experiences are or accumulated radiology knowledge that you've gotten over your years of training. So things keep going increasingly abstract, and it's more difficult to determine as you go down this hierarchy where the source of knowledge comes from. And we actually haven't even gotten to solve this base of this hierarchy, which is just like looking at current and previous imaging and trying to see how we can kind of get to this interpretation, or how we can kind of correlate between this current and previous imaging to this interpretation, let alone go down further and further towards more abstract sources, right? So and if you think about this from a perspective of so this was from an example of how a radiologist would do their task. But if you kind of extrapolate this to how humans would generally do this, then I usually like thinking of this from a perspective of this theory of cognitive development from Jean Piaget. And in this sort of theory, it's like, you learn things at different stages in your life. So when you're a child and between birth to 2 years, you first understand like this perceptual sense of the world, which is like, through your senses, which can be like vision, hearing, and through like how you do actions and interact with your perceptions. Then you move on to, again, more abstract sources, which is like between 2 to 7, you go into the world of language and like figuring out mental images through language. Then you go into more like logical thinking and like categorization, which is like one step beyond language. And then you go into more like abstract hypothetical thinking and like reasoning. So as you can see, like even the way we learn is kind of like stacked up and like goes increasingly abstract. So the idea is we probably should train models in a very similar way to go from something that is more perceptual and immediate and less abstract, and then you kind of build on to it going to more and more abstract domains. So my work has focused a lot on the base of the hierarchy, which is like looking at like perceptions or looking at the vision part of things and seeing how best can we learn representations and how best can we understand these images through these representations, so that when you kind of stack on more abstract layers, um, these can go hand in hand and kind of go better with the base hierarchy than just like starting from the most complex one. Um, so yeah, so when we're looking at like building foundation models for vision or trying to understand this base of the hierarchy, which is vision, there's also an hierarchy within itself as well. So if you look at this top here, this could be like a general vision foundation model where you're looking at images from the natural world, things that have been acquired through your camera. And you would kind of understand things differently in that space, as opposed to looking at a space where you're looking at like CT scans or you're looking at MRIs or you're looking at ultrasound. So if you're trying to learn a foundation model in this space, you would want to learn a foundation model of a different kind for CT or MRI if you expect it to be optimal. And then beyond just modality specific foundation models, you could even go into foundation models that are more use case specific. So if you're familiar with Segment Anything by Meta, I think that was one of the biggest, the most popular use case specific foundation models where, you could pretty much segment anything on any of these natural scans, natural image scans. And we saw that there were also different variations of it, like MedSam, which was like medical image segmentation. And there's also multiple different ones, variants of SAM specifically for like radiology as well. So there can also be a huge range of use case specific foundation models, in addition to having like modality specific foundation models and just in general vision specific foundation models as well. And I would think of this not from a perspective of like each one of these being like independent foundation models, but I would think of these as like kind of like flowing through the hierarchy, right? Like you could start from a very general natural image vision foundation model and then kind of move over those representations from the general image to understanding better an image of a specific modality such as CT. And then from that, you can kind of go further into understanding how representations for most optimal segmentation in a CT might look like. So this again kind of goes down into this like theory of cognitive development where you're trying to like go from something like very general, like something that's very generalizable here in case of vision, and then going more down to like specifics and more specialties and things that get more abstract. And one of the first studies that we worked on is in this use case specific foundation model. And we tried to see if we can build a foundation model for understanding cancer on CT imaging. And what we call this was like an imaging biomarker, because this kind of gives you a sense of like the underlying biology or like the pathology of cancer, but through CT imaging. And if you're unfamiliar with imaging biomarkers, then one of the first large-scale studies that kind of investigated imaging biomarkers on CT scans was in 2014 by Ertz et al., who also happens to be my supervisor. And what this study did was this tried to quantitatively analyze medical images. And this was done by kind of, if you see this image here, do you see my cursor as well? I hope so. I've been using it. Okay, perfect. So yeah, if you see this like highlighted kind of mask here, this is a mask that outlines the bounds of the tumor. And then once you have this mask, what you can do is you can run certain statistical and mathematical kernels on it to get estimates of different things that you might be interested in. So you could approximate the tumor shape based on that. You could get a distribution of tumor intensities. You could understand tumor textures by things like understanding gradient changes in the intensities. And you could also do higher order transforms, such as like wavelet transforms, and decompose it into like a frequency representation and understand what happens there. And the idea is they're able to capture characteristics of the tumor, which are kind of distributed in like. Oh, no, no. Yes, Yuri.
Oh, I'm wondering if these are 2D or 3D.
Yes. So you could do this in 2D as well. Um, I mean, so I think in this 2014 study, it was done so it was done over 3D, but there are filters that are also applied in like 3D. So it's like, it's a mix of both 2D and 3D, but the work that that we did, and like I'm going to talk about like a deep learning approach as well that kind of replaced this kernel based approach or like predefined kernel based approach. Those were all done in 3D because it just makes more sense to do this in 3D because you just have more sensible context there, and because you're looking at a tumor from a three-dimensional perspective, you would also want to contextualize that information and not do it like independently slice wise 2D and then aggregate it later on or so.
Thank you.
Of course. Right. So the idea was use different kinds of mathematical, statistical, predefined kernels and try to capture characteristics within that ROI in a CT image, which could go beyond size and things like pathology that's gotten through like surgical dissection. And usually you would mostly look at like things like TNM staging as an imaging biomarker, like clinical TNM staging. But here you could have more, let's put it as a more abstract way of kind of capturing this. And a huge benefit of doing this sort of imaging biomarkers is they're non-invasive. And this sort of imaging is already done in existing workflow. So you wouldn't need to add a separate workflow to integrate this into clinical practice. So they are easily integratable. And we hope that this would also complement other clinical variables such as TNM staging or like just tumor volume. And yeah, so this study kind of established that imaging biomarkers are an interesting thing to look at, and they could kind of help you understand how a tumor might progress, and like if you might want to quantify a particular prognosis of a specific kind of tumor, you could leverage things like imaging biomarkers over TNM staging. And in 2018, there was a study by Hosni et al. Where they, instead of looking at like these predefined statistical kernels, they tried to see if they can use deep learning. And what they did there was they just took an entire block around this tumor and passed that as a 3D patch to a deep learning model, and then used that to predict survival directly. And then because of this, they were able to kind of go from an image to a confidence or a probability of like what the prognosis of a patient might be, and then kind of use that to correlate with survival. And yes, Sonali.
Yeah, so this is not really my field, the images. I work mostly on clinical data. So I'm wondering, to train this model, how did you create labeled data? So did radiologists kind of by hand marked the boundary of the tumors that they saw, and did that serve as the training data? What do you train the model on?
Yeah, yeah. So I think one of the nice things about working on this sort of research is that what I meant with like easily integrating into clinic existing workflows, I think this also bodes well into what we need for this, because a lot of these scans are done for, or a lot of the data sets that were looked at in these studies were like radiotherapy data sets. So these tumors were already annotated as a part of the radiotherapy process because you would need these to optimize a certain treatment plan. So these data sets would generally already have like comprehensive tumor annotations along with annotations of like organs at risk potentially. So we already obtained, or at least in these studies, they already obtained a set of ground truth labels that was a part of the clinical workflow. So there was no reason to like go beyond and collect a separate a set of label data there.
Awesome, thanks.
Yeah, of course. Um, so yeah, from the deep learning approach, we tried to see if there was like a kind of a research gap between how the deep learning sort of way of doing this versus the statistical kernel way of doing this. Was there something missing along these two pathways? What were still challenges in these sort of imaging biomarker studies that kind of makes them, we saw that they weren't actually being adopted as much in clinical practice. Was it because they were just like a kind of trust issue, or was it because like they just didn't work so well? So we just wanted to kind of figure out where the gap was, and we saw one of the things that really happened was like you would develop these kind of independent siloed models that work well on like one cohort, or that would work well on like one certain clinical treatment cohort. Like, for example, if you were looking at like patients for a certain kind of radiotherapy, then that would work well. But if you go to a patient cohort with a different kind of radiotherapy, so for example, if you're looking at like site-wise head and neck versus like lung, these would not generalize. So you would kind of need to build separate deep learning models for each one of this. Now, if you're going to compound this with like also people who are getting treated with like chemotherapy, immunotherapy, concomitant therapies, these would kind of explode. And then you would need like different deep learning models for each one of these subsets. So we saw that the transference or like the ability for these models to transfer wasn't really there. And this makes sense because a lot of these imaging biomarker studies were designed to answer like very specific research questions. And then as a result, you have very small data sizes. And for deep learning, it's kind of already well established that like you need very large data size, very large data sets to make sense of this. So training on these very small data sets leads to then like I said, models that don't transfer well, less robust models, even for things like external validation, say even the same kind of treatment cohort with the same kind of acquisition setup, you go to a different center, maybe it doesn't work there. Even things like temporal validation, where you kind of have the same setup in the same center, but you get like a new set of patients who come in, and because you have like some sort of distribution shift, just because imaging has gotten better or circumstances have changed in the clinic, you still see that these models kind of don't transfer. So there was indeed a research gap here. Um, so we thought, like, is there a new way of doing these imaging biomarkers? So when we started the study, foundation models already started kind of like becoming popular, where you do this like large scale self-supervised pre-training. You look at like more generalizable, robust models which work well in like low data settings, which by owing to their pre-training, they kind of like build this robust set of representations, which means that when you actually train it, when you train it on like the actual data set, they can still work or still do with like having smaller sample sizes. So we thought, why not build something like this for this imaging biomarker space for cancer? And we kind of we did this like about like a bit more than a year ago now, and I'm just putting this in the hierarchy here because, or well, in this timeline here, because I hope that this becomes a way where people start like using this foundation model for analyzing like their imaging biomarker studies. And the way we built this foundation model was, so there's generally for building any foundation model, if you think of a recipe, then I think there's like three main components that you would have here. The first is data. You need large scale data that can capture exactly the kind of nuances that you hope to solve with the foundation model. Then there's obviously the way to train this foundation model, which is like how best can you get representations for these foundation models from the data. So this goes into like the technical methodology side of things. And then the third and the final one is obviously compute. Like you need like a good amount of compute, and you need like a good amount of GPUs to run this foundation model. So the one that's usually the most tricky is the data, because actually getting the methodology, there's been so many developments in strong methodology in like general computer vision. So bringing it down to like medical imaging, that's usually there's still some work to be done there, but it's not usually the biggest challenge. Compute, that GPUs are much cheaper now. Like most hospital centers and cancer centers have like a good collection of GPUs that they have in-house, so that's not that much of a problem either. But the data, where can we get like this large scale data to build this like foundation model for cancer imaging biomarkers? That's something that was initially one of the big challenges that we had. So we looked at this data set called deep lesion. We just happened to find this at some point. It is actually much more popular now because they based a few challenges off this. But when we actually started working on the study, this was like a pretty undiscovered data set. And this data set was like actually collected by the NIH in their clinical center. And it had 32,000 lesions from 4,000 patients across 10,000 studies collected over, I think it was like a 12-year period that they went back into their packs and pulled out this data. And a lot of this data was annotated, but annotated very sparsely, at least if you were to be using this for like a deep learning quantification way. Because what they did was a lot of this data just had like RESIS diameter bookmarks. So it would just be like you take the the slice in the 3D with the largest diameter, and then you would just have like one rhesus diameter bookmark on it. So you don't actually know the full 3D extent of the tumor looking at that. You don't actually know the full shape of it, like I showed you in this previous ROI part of things, where you actually can like quantify the entire shape in 3D. You don't know this in this data set. You just have like one 2D slice with this bookmark. Um, but we thought this was actually like the perfect data set for us to use for this study, because oh, another thing that compounded with this was like they had some target labels for this data set, and by target labels I mean like they had like labels saying that this scan contains lesions that are in like the kidney, or lesions that are in the bone, or lesions that are in the lung. So they had some sort of target labels there. But yeah, most of the annotations were only 2D. Full 3D bound of the lesion was not to be known. So we thought this is perfect because this is best fitting into like the self-supervised contrastive learning workflow, which I'll talk about shortly, where you can really be okay with a lot of like noisy data. And I'll get to exactly how we use this data in the self-supervised learning workflow, where this data couldn't really be used in like this previous deep learning workflows, or in like this traditional imaging biomarker way of doing it previously. So yeah, now I'm going to be talking about like the learning algorithm that we used here. So before I talk about like the specific learning algorithm that we use for this, I kind of want to just talk a bit about like contrastive learning in the general image space. I'm not sure if this is something that is familiar to everyone, so maybe it's good to do a general thing here. The basic idea with contrastive learning is to figure out what makes two instances similar, or what are similarities between images. So here, if you look at like this example of a cat, you kind of want to be able to say that, okay, this image of another cat, although it looks kind of different, is still an image of a cat. Whereas if you have images of like, say, for example, a dog or a bird or an elephant, this is something that should be different. Now, in practice, you don't actually look at two different instances, but you look at something that is called augmentations, or transformations of the same instance. So here, if you look at this image of this cat, what you do is you kind of like break it down into different like chunks. So these chunks can also be like differently sized. They can be like, a crop from like some part of the corner, or they can be kind of like skewed as well. Like you could have the same cat image, but kind of like warped. So you do these sort of different augmentations, like you induce these transformations or augmentations. And then, so here, if you see, you have like this upper left part of the cat, and here you have like this bottom right part of the cat. But essentially, these two are coming from a singular cat image, and you know this because you've induced these augmentations from a single image. So you use this sort of idea to learn an encoder which can give you these sort of representations then. And how you learn this encoder is, like I said, this come from the same source. So you ask, or you basically train this encoder to understand that the representations that come as an output of the encoder, they need to be very similar. Um, so that's the general idea of contrastive learning. But what could just happen is the encoder could always just predict, like it's usually like a vector output that comes from the encoder, which is a very high dimensional vector output. But let's just assume this is like a single scalar value. So it could always just predict one. So irrespective of like what input you give it here, whether it be a cat, a dog, you break the transformations here. And if it's always predicting one, then these will always be pulled together. Like you cannot like the most optimal solution here is to just predict a single same value, because then you've kind of already optimized the values being similar, right? So what you need to avoid this is something called like this push apart mechanism, where you have an image of a different instance, and this can be an instance of something that is not this specific cat. So if you have an instance of a dog here, then you again break down a crop or like an augmentation of this dog. And when passed through this encoder needs to learn representations that are different from the representations of the cat. So here what happens is you're kind of saying that the encoder has to learn to identify what makes a cat by breaking it down into like different views and augmentations. But at the same time, it has to understand that a cat is different from a dog. And this dog could be like anything else, right? This could be an image of a car, this could be an image of like a building, and like you just sample this from a huge data set, so you have instances of all different kinds. So then you kind of understand what makes an instance and what makes it different from another instance. And the nice thing about doing this is it's all like self-supervised or unsupervised, that you don't need any labels here. You just need to understand like you just need a set of instances, and then you kind of understand how to learn relationships within an instance and between instances. So yes, Yui.
Hi, so what if you have two photos of two cats?
Yes,
Um,
that is a fantastic question, and I think that is something. So this was from like so this is actually the contrastive learning method used here is called Sinclair, and this was like actually the citation is just from where the image is. I should have actually put the original study citation. But yeah, this is something that they did not fix in their original method. That if you had the same instances of like two cats, then what happens? Like this was, they just kind of assume that at the scale of the data you have, where you have like a huge number of diverse different instances, you're okay with learning things that are specific to one instance, but not like class groups within that instance. So like a set of different cats would be like a class group. A set of dogs would be like a class group as well, but they kind of focus on just learning like for one specific instance and not across class groups. And this is something that I will have in like the next, I guess like 2 slides, because we saw that this, like if you don't like think about class groups, then this does not work well for training something for like, for example, like tumors, or for identifying imaging biomarkers in radiology images. Um, so yeah,
thanks.
it's a very intuitive question for sure. And yeah, and another thing is like beyond what you pointed out or asked here is that these commonly used methods might not like really learn the representations we would like it to, solely because they're based on like large differences that you see in natural world images. So if you can try to spot the difference here, like this is like the ImageNet data set, where you can immediately see there's like a wide range of different color, wide range of different like images. But when you look at like deep lesion here, it's all very different from a perspective of human vision. So this also compounds with the fact that if you look at like looking at very specific instances and not like class groups, this doesn't really bode very well for using the contrastive learning method directly over here. So what we did was we developed this modifying contrastive learning framework, which is actually really simple. And what you do here is you look at like a volume with the lesion. So because you have this like RECIST bookmark available for this deep lesion data set, we know roughly what the center of the lesion is. So based on the center of the lesion, we crop a box around this lesion. Obviously, this box is an estimate, so it might not capture the full bound of the lesion, but we try to get like a decent enough distribution of lesions here. And what you do is for this volume with the lesion, you make like 2 different augmentations and you help them learn similar features. So this is exactly what we did for like the cat image before, but now for a lesion. And then what we do is the negatives, the images of the dogs in the previous example, those are not actually other lesions, because what if 2 lesions are pretty similar? What if lesions are are of the same shape there? We don't want them to learn very different representations then. So what we do is we sample volumes that do not contain lesions from the rest of the CT scan, because we know where the lesion is, it's very easy for us to know where the lesions are not. So we just sample then instances that do not contain lesions, and we say that, okay, we want our encoder to learn representations where it understands that or it understands what makes a lesion, because it's looking at like these 2 different views of the lesions. But at the same time, it understands that a lesion is different from any part of the anatomy that doesn't contain a lesion. So in our entire training samples, you would even have like, so for example, if you had a lesion close to mediastinum in the lung, then you would also have a sample of the of that lung mediastinal region without the lesion. So then you kind of know that these two are supposed to be like different when you look at like the scale of the data sets. So yeah, this was basically the modified contrastive learning framework we had. So if you look at like the original Sinclair style contrastive learning framework, then what you would have is, if you're looking at like a lesion or some sort of reference abnormality, then you try to learn that every instance is separate from the other instance. So then you kind of have this thing where similar instances might also be grouped together. But in our case, what we do is we understand the nature of a reference abnormality and help it or like learn the model recognize that it's different from what a normal patch from the scan is. So we kind of move from looking at like abnormalities as instances versus like choosing an instance of abnormality and choosing instances of normal patches to kind of contrast against. I hope this is clear. And then we take this framework, and then I'm going to skip this slide. I think I'll skip this one as well, because this was just to show that like the dark green one is the method we did, but we kind of wanted to show that doing it the way that Sinclair or the original cat dog version of doing it was actually worse than what we were doing. So that's kind of what we wanted to show. So that's what the slide is here. But yeah, more onto the use cases of what we get from learning this imaging biomarker, right? So what we have here is we get a pre-trained foundation model, and then we apply this foundation model in different ways on 3 different data sets. So first data set of like technical validation, where we see if we can even capture like where these lesions are coming from. Are they coming from like are they kidney lesions? Are they bone lesions? Are they lung lesions? That was the first thing that we kind of want to capture. Then we have this diagnostic biomarker, where we try to see if like given a nodule, is it malignant or not. And then we also have this prognostic biomarker, where given a lesion, you want to understand if or you want to understand what the estimate for survival post treatment of that particular category would be. So we first saw that this foundation model can differentiate lesions across different anatomical sites. I don't think it's very interesting to go deeply into some of these results here, but I'll just say that like the blue ones are the models that we trained. And then you also have this in dark black, the older way of doing it, which was building a supervised deep learning model. So we see that using our methods, you get much better performance than using this like fully supervised deep learning model. And this light blue, I think, is the dark blue and the light blue. That distinction, I think, is also interesting. So I'm going to talk a second about that. Where if you took this fully trained, pre-trained foundation model, you could actually fine tune it on the task. And by fine tune, I mean like you change the entire weights, you do a full deep learning process, and that gives you a way of identifying the outcome. But then what you could also do is you can just like keep the pre-training part frozen. Like you can just say, okay, I use this pre-trained model as a fixed feature extractor, and this gives you a set of features, like for example how you would have in like I guess like a set of like genomic features or so. And then you build like classifier models on top of these features. You don't touch the actual deep learning head of it, but you just take these features and then you build like simple linear models, or very simple non-linear models even on top. And what we saw generally here when you reduce the amount of training data is that the ones in dark blue, which are the ones where we just like extracted the features and built linear models on top, we actually just built a simple logistic regression model. We see that these ones actually stay more stable when you drop the amount of training data. And then I think you'll see that in some of the next results as well. But yeah, another image here to kind of show you like that looking at these representations and trying to understand where they come from in terms of anatomical side, the model is actually able to capture pretty decently. So you can kind of see like lung lesions versus like mediastinal lesions. And you can see this even to some extent with a very simple PCA, but very definitely so in a TSNE plot as well. And then, yeah, moving on to the next use case, we also see that FMCIB can help determine nodule malignancy. Given a nodule, is it malignant or benign? And then again, you kind of see a very similar sort of trend here with a dark blue, which is just looking at features, that if you drop the percentage of training data even to like 10%, which is, I think in this case, about like 40, 50 samples, if I remember correctly, it's still able to stay robust in its performance and not drop drastically from having like 100% of data. Where if you look at like the deep learning way of doing this in this light blue, it really drops when you get to like 20%, 10% data, which is kind of the problem that we were trying to solve in the first place. Like, how do you transfer these models? Um, and then FMCIB can also provide prognostic information. And we did this with like specifically radiotherapy cohorts. And here you see that actually using this foundation model features in this dark blue and not actually fine tuning works the best. And you also see that using these foundation model features can also stratify cohorts based on like high and low risk. And then if you fine tune it, then you see that the stratification ability actually gets worse. And we actually weren't sure why this is the case, why the features work much better than actually fine tuning. Because, in general, if you just fine tune something with a decent amount of data, it should work out pretty well. But in this case, I think the reason is because the task is so complex, trying to identify what a prognostication for a cohort from just looking at imaging would be, that even if you have a decent amount of samples for like what you would think is enough for like more simpler tasks, when the task gets more complex, you would actually need a factor of magnitude more data samples for it to work well. So in this scenario, we see this as like, when you look at the complexity to the amount of data ratio, then our models are still in a low data regimen in that sense. So the foundation model features actually work here better than actually the full fine tuning. And then, yes, Yuri.
What could you talk a little bit about supervised versus supervised fine-tune?
Supervised was supervised fine-tuned. Yes. So wait, give me a second. Foundation features. That's the one in the dark black versus the slightly lighter one. Is that the one you're asking about?
Yeah.
Okay, perfect. So supervised was something that we trained from scratch. So as in like this model was randomly initialized before it actually even saw any data from this RT cohorts for training. So that's the supervised one. The supervised fine-tune one was because we actually built two other models previously here, like one for identifying the lesion anatomical site and one for nodule malignancy. We thought we could like take those previously built models and then fine tune them on this new task. So in this case, the supervised fine tuned is we took a model from the nodule malignancy, and then we fine tuned it on this prognostication task. So we're kind of trying to see, is there like some kind of utility and also like task transfer? So is a model trained on a previous task that is of similar nature also going to benefit when you transfer it to a new task? So the supervised just says it's a blank slate, and the fine tune one goes from like a previous task. Hope
Got
that
it.
makes sense.
So
Yeah.
for the supervised, do you start with weights trained with either ImageNet or CoCo dataset, or is it completely randomly starting?
Yeah, it's completely randomly starting because it's a 3D model. So unfortunately, the ImageNet weights don't like apply as much to us because the ImageNet weights are in 2D. We did consider some sort of like there's approaches to like inflate from 2D to 3D models, but I don't think they work that well in general. So we just decided to not do any sort of like general domain pre-training.
Thank you.
Course. And then we saw a similar sort of prognostic behavior for surgery cohorts as well. And we saw that this is kind of a new way of identifying imaging biomarkers that are very inspired from self-supervised learning studies that are done in the general domain of natural images, and self-supervised studies in like medical imaging beyond looking at like cancer imaging. And we saw that this sort of pre-training provided us very like robust and generalizable features. And then that training on a feature level, specifically looking only at features on small cohorts, provides us pretty good performance. And a really nice thing is that this foundation model doesn't take much compute at all. Like it can run on a standard like a MacBook, for example. It doesn't need a GPU. It doesn't need anything fancy. So it's very simple and low resource, which means that we can hopefully democratize the use of this as opposed to like the deep learning way of doing it, where you would actually need to like have GPUs to train anything. Here, you just like use features extracted on a MacBook system and build a logistic regression model, which you can do again on like a MacBook potentially. And to make this like very usable for people and like again to push this agenda of democratizing this, we also make like a very easy kind of way of having people work with this. So it's a pip installable package. So all you would need to do to use this is say pip install foundation cancer image biomarker, and then it's one simple function call, provided that you kind of like set up your images in this CSV format, because all you would need is, instead of like what I showed you earlier for the ROI, you needed like a full 3D mask. Here, all you need is like a seed point, because we're going to extract a cube from this seed point. And then you get like your features extracted, and from these features, you can kind of build your own set of models and like tie it out to different outcomes. And then we saw that like because we made it so simple and because we made it like easily accessible, we saw that like I think the study was done like 3 months or 4 months after we published our paper and after everything went like public. And um, like these authors hadn't even reached out to us to figure out how things were, and they just like did this themselves in like 3 months, which I think is a pretty good sign that it was easy to use. And they also saw that like the results were pretty good when they tried it on like their own internal data sets. So there's a couple of folks from Duke, and they also extended it, like they revalidated this on the data set that we did, and then they also kind of added a new NLSD data set, which is also public, which we used in some of our later studies as well. But yeah, basically they were able to replicate our results, apply it on new cohorts, and apply it on their internal cohorts, which is really the research gap that we wanted to kind of find and fix. That this can be transferable and applied and reproducible and scaled. And then since then, we've also seen like a lot more people use this and like find pretty decent results. So I think we were okay-ish with trying to close that gap, although there's a lot more work to be done in making it like something that gets into the clinic. And like right now, it's finding its way into like other research studies, but actually having it be taking place in like a standard clinical workflow, I think that's a whole different ballgame. So, but at least it's starting somewhere. Um, how much are we? How are we looking on time, Sonali? I can. Sorry. Oh, I cannot hear you, Sonali.
We're 2 minutes past time.
Okay, then I will just stop here.
Yeah.
I think, yeah.
Yeah, sorry everybody. Just so, is there one last question for Suraj, or do you want to conclude with one last slide, Suraj?
Yui, yes.
Excellent talk. Thank you. I just have one last question about the radiomics features that are deep learning era and compare. What are your thoughts on the performances between these two different ways of doing things?
Right. So let me wait. I have this. Okay, you see this one here, right? So this wasn't something that we did in the original paper, but we saw that like, so we kind of compared our foundation model features versus traditional radiomics versus like clinical features. And clinical features here are like TNM staging, age, gender, and I think there was also volume. I'm not too sure, but yeah, we basically had like things that were used standardly versus like traditional radiomic features. The thing we saw with traditional radiomics features is that they're notoriously difficult to optimize in the sense that there's so many different configurations of kernels, so many different feature selections, so many different like hyperparameters that you have within this like search for finding out how many kernels that you need to use are optimal. What dimensionality of kernels do you use? Do you use wavelet? Do you use like stack? There's so many different variables there, and there's like entire research papers on like finding out what the most optimal setting or optimization criteria for finding out what radiomic features work best for a certain application is, right? So there's an entire category and set of papers there. And I'm pretty sure we did not find the most optimal performance on this data set, and there's studies where they might have spent way more time finding the most optimal criteria here. But what we kind of wanted to emphasize on here is that if you look at foundation model features, they provide much better performance than the traditional radiomic features. And in some cases, like in radio, the clinical features are very comparable, even much better actually than the foundation model features. And this makes sense because radio is more of a surgery cohort. So if you add TNM staging into a set of features for the surgery cohort, it makes sense that it would perform much better. Whereas for lung one, which is a radiotherapy cohort, where you probably couldn't just base it on things like TNM staging, or that there's more to than just using TNM staging, there this sort of marker provides a better performance. And here we just use a linear regression model on top of the features, and we barely spend any time optimizing other than just I guess a couple of parameters for the linear regression. We actually don't even do any feature selection. This is the entire set of embeddings that you have from the foundation model, no feature selection at all. And so that's the thing, we kind of want to stop people from using traditional radiomics because I think people spend a lot of time there on trying to optimize something where you could kind of get that same sort of performance either with a foundation model or actually just using simple clinical features, because you see that the clinical features are better here, and these clinical features are obviously going to be captured in the cancer pathway as well. So sorry, there was a bit of a long drawn out answer to maybe what is a simple question, but yeah, I hope that answers your question still.
Yeah, thank you. That's great insight. The AUC is 0.65 here, right? So
yes,
that's so there's some way to go before it's clinically
absolutely.
right. Informative.
No, I think the thing is we've been focusing a lot more on what you can do individually with imaging alone. So this was just the foundation model features, right? We haven't really tried combining it with either clinical features or even, for example, you could combine it with even free text, for example, in this era of agentic AI and foundation models. Because now we are really operating in the representation space here. So you could also have a textual representation of say the patient history, and together you could kind of optimize this, right? So we haven't really spent too much time with that because we just thought that the imaging still has some work to be done before we can get features that are meaningful enough for multimodality. But yeah, maybe next steps where we actually try the more multimodal way of doing things.
Thank you.
Yeah. Sonali, I think your voice is missing again. I don't know if it's just for me actually. But
no, I think it's my laptop.
Oh, okay.
Is this
Yeah.
any better?
Yeah, I can hear you now.
Yeah.
Yes.
Yeah, I want to turn off my camera because I need to get really close to the microphone. I was just thanking you for an excellent talk, and we are 8 minutes past the time, and still everybody is here. I think that is a test to how interested everybody is in what you have to say. So thank you so very much for joining us again. I'll put this talk on YouTube and I'll post the link. If you are still available, Suraj, there were questions, and if anybody has questions, let's formally conclude it here. But if anybody has questions, and if you are okay to stay for a few more minutes, some of us can stay and chat if you like.
Absolutely, I'm happy to stay.
Okay, thank you, everybody, and have a wonderful long weekend.
Thank you, everyone. Have a great 4th of July weekend.
Did you have additional questions, Yogi?
Sort of, yeah.
Awesome.
Yeah.
Just continuing the conversation on the last slide you shared there. How much of an overlap do you think there is between the imaging features and the clinical features, such as the staging, the tumor stage?
Yeah, that's a fantastic question, right? Because I think even one of the things that we really wanted to look at is also volume. Because if we have a full a lot of these scans, as I mentioned, the tumor has a full 3D kind of segmentation on it, right? So then you really kind of can capture the volume as well, which is maybe even a stronger factor than like clinical TNM staging sometimes. So we saw that a lot of times the foundation model features are like kind of correlating with volume, but not really. In a sense that there is a weak correlation, but there seems to be something beyond just volume being captured in them as well. And also the fact that um, because we take like fixed sized bounding boxes around the tumors, that there are a lot of cases where the volume might not even be estimatable for the model, because if a tumor is larger than the kind of bounding box that we take, then we're kind of really missing the criteria that you would need to identify volume in a model. Um, but yeah, so for volume, that was the thing. And then for clinical features like TNM staging, that is really, we again see that there might not be a very strong correlation between TNM and the foundation model features, but there is still some sort of correlation between these two. And I would like to think that they're like complementary and not like, um, not really like kind of replaceable with each other, right? Because um, the thing is, we don't really, because this way of pre-training is very generic and it doesn't really constrain the model with actually identifying anything specific. I think there's a stronger argument that this sort of pre-training can be used for like just features that are beyond just PNM staging and can be more generalized.
Yogi, there is a lot of noise, background noise where you are. Thanks. So,
Yeah.
yeah, I'm very curious to see what AUC you get when you combine the foundation model features and clinical features.
Indeed, indeed. I think there's been some follow-up studies already that have kind of like, I don't know if I listed one of these here. Uh, yeah, I guess this one actually was like a foundation radiomics and clinical features in locally advanced small cell cancer. So I think people have, I try to keep up with a lot of the papers that use this so that I know what like people are working on. And people have been able to get pretty good AUCs of like zero point 0.8 and whatnot on their like local cohorts by using these foundation radiomic features and then combining with clinical. And it's almost always been the case that, to add on to what you'd asked as well, Yui, it's almost always been the case that um, using just the foundation model features are not enough, and that you need to combine them with clinical features. But also using clinical features is also not just enough, and then combining them both really provides the strongest performance. And I've kind of seen this across like more than a handful studies, that the benefit is always in like combining these, even if you look at like very rudimentary ways of combining it, just as like concatenating the feature space and then like using that as a data point. But what we're kind of really hoping would be the next generation way of doing this, which unfortunately, because I finished my PhD and because I've kind of moved on to like a different position and doing different things, I don't really have the bandwidth to explore anymore. But like doing this in a truly multimodal way, where you kind of like have a separate model that looks at these clinical features, and like you might even think of this as like something like a chat GPT or LLM style model, right, where you can provide it like maybe like structured clinical text, but in like text, like in textual format, and you use the representations that ChatGPT or like this LLM captures, and then you use these representations along with the representations of this foundation model that we have for cancer imaging, and together you jointly optimize them and use them to predict. I think that would be like a much more holistic way of doing this. And a lot of people are already doing this sort of stuff for like not for like cancer imaging specifically, but they're doing this in like general CT domain, where they're looking at like um, you know um, imaging for like they're actually looking at potentially things like segmentation or report generation, and they're giving like previous reports as text information and the current CT, and then like using that together to generate like maybe a an independent CT report that can be like an assisted report for a doctor. So yeah, I think the truly multimodal way to do this would be like kind of have a jointly optimized framework.
That's awesome. I have a question about your very original training data set, the data set that you started with. Do you know
Yes,
how
yeah.
representative is that data set?
That's a very good question. We kind of like this data set is really it's a so I think the NIH released this maybe not with an intent to have it become like super popular. At least that's what I kind of thought, and maybe I should go off the record here. But yeah, because like there was no accompanying information whatsoever with these scans, like not like any sort of like demographic information, not any sort of like basic information of like, let's say even like um so 5,000 ones had like what site they came from at least, but not even the types of like what might be like the diagnosis for the cancer for these certain things. There was really a lack of information with this data set. That's why we thought like we can't actually use this data set for any sort of like sensible training, because there's really like nothing in this data set that we can ascribe to like the real world variables or something of that sort. So that's why we thought like this is the ideal data set for like pre-training, uh, because this data set is so mysterious and we don't know the actual composition of it. Using it for pre-training probably is like the only thing you can do. But yeah, I think even for pre-training, it's difficult to say how representative it is. Like that's something we've struggled quite a bit with about in terms of like the original start of this project of like, should we use this data set? Like, what will it really capture? And I guess in our situation now, we were like, okay, if it works, it works. If it doesn't, then we know that this data set isn't representative. So it seemed like it kind of worked. So that's the honest answer, really. Uh,
Thank you, Suraj. I'm going to stop the recording.
yeah,
Thank you very much.
absolutely.